Well, good morning, everyone. It is Friday. It's time for our kind of compilation video. Our languages this week were Lingala from the Congo, Esperanto, which is really cool because it's actually the first truly constructed language. It was meant to be an international language that everyone could kind of speak. And then finally Quechua, which is a native Incan language or something you'd find in Peru. So anyway, our topics were we were talking about cancer therapy and hormone therapy in cancer. There's a lot that goes into this, and I had a lot of people reach out and ask questions, and I really appreciate that because obviously the purpose of this channel and my social media channel really is to educate people and to provide education. So, I want to point out once again that if your symptoms are of the kind of gynecologic hormonal nature, so things, we'd associate with menopause or with, vulvovaginal type changes, the North American Menopause Society every year or so puts out a new consensus statement on hormone therapy. Their 2022 consensus statement came out earlier this year. It's for free on www.menopause.org. And it basically goes through it, and they've compiled all that data there, and it goes category by category, talks about all the different applications, uses, things like that for hormone therapy. So that's where all this data is coming from. So if you have a provider that kind of seems recalcitrant, you can say, hey, here's a place you can go to feel comfortable in prescribing that. Or if they still don't want to, find someone such as myself who is very happy in prescribing these and prescribes them all the time. So anyway, to get back to the heart of the matter, and really when we talk about hormone therapy and cancer, the thing that always comes up is breast cancer. And that's because there was a study performed in the late 1990s, early 2000s called the Women's Health Initiative. I've talked about it before, but the short end of the study was basically that they were looking at women who were on average 65 years of age and had been more than 10 years post-menopause, and they were starting them on hormone therapy to help combat things like hot flashes, night sweats, things like that. And while the study was looking at a bunch of things, and in this specific part of the study, they divided them into three groups, and they had kind of a control group that was a control group, no medication. They had an estrogen-only group, and then they had an estrogen and progestin group. And the hormonal groups were given a medication called either Premarin, which is a conjugated equine estrogen, or an estrogen made from pregnant horse urine, an oral pill of that. And in the progesterone or progestin and estrogen group, that was a medication called Prempro, which is a mixture of Premarin and then Provera, which is a medroxyprogesterone acetate. It's a large molecule progesterone, or progestin because it's synthetic. And so they looked at a bunch of things, but they ended up halting the estrogen arm of the study early because they saw a slight uptick in the rate of deep vein thromboses, heart attacks, stroke, kind of issues related to blood clots. And this makes sense when you look at this kind of overall, because estrogen, as we know, can increase your risk for thrombosis or from throwing a clot. And the other thing to consider is when you take an estrogen, or especially a testosterone too, but if you take either of those orally, that goes through hepatic first pass metabolism. And sex hormones are steroid, or they're cholesterol steroids in origin. So they get broken down. It can increase your cholesterol, actually, and then that can, in theory, kind of increase that chance for having clots. So, while yes, that is still a risk, and that's something we want to talk about, there was actually no increase in the risk of breast cancer in that group. They actually saw a slight decrease in it. They saw a very substantial decrease in the rate of colon cancer. And so, but still they said, well, we don't want people having strokes, so we pulled that arm early. In the Prempro group, they pulled that one early too, and this is what was leaked to the media, because they saw a slight uptick in the rate of breast cancers. Now, that was kind of the data, that's all that the media got. They said, oh, it's increased the rate of breast cancer, and the country went haywire, and some parts of the world went haywire as well. And basically, all of a sudden, no one was prescribing hormones because it was causing breast cancer. Well, when you actually dove into the data, and once they had actually finished compiling the data and had really kind of looked at it, what they saw is that that extra rate of breast cancer was an extra 1 out of every 1,000 women per year would develop breast cancer. That's roughly the same risk as if, or it's actually less risk than if you smoked cigarettes every day. It's roughly the same risk as, eating an unhealthy diet, drinking more than 2 glasses of alcohol a day, like things like that. So yes, technically it increased it, sure, but at the same time, it's actually less than a lot of other things that are out there. So, and this is why it's so important with research studies that, you have to wait until they're fully done and fully, the data is compiled before you make a decision about it, because otherwise you can lead to premature, issues. But anyway, hormones became bad, hormone therapy became bad, and it became synonymously associated with breast cancer, when actually that's not the case. So, and even to the point now that, any type of estrogen containing product in the United States has this little black box warning with it. Warning, this will cause, cancer, dementia, your face to fall off, all these bad things, when once again, that's not the true data. That was based off of that premature thing back then. So what we know now is that if you wait more than 10 years post-menopause to start hormone therapy, yes, you can see a slight increase in the risk of cardiovascular disease and things like that. But starting it prior to that 10-year mark actually decreases that risk. And for cancer patients, or patients who have been through cancer or who are, actively battling cancer, we can actually use a lot of hormones in a very appropriate way to help their symptoms. So that's kind of the backstory. So with breast cancer, the big thing, you have to look at is, what type of receptor positivity does your breast cancer have? Is it an estrogen receptor positive, a progesterone receptor positive, or HER2/neu positive cancer? And what this means is, if that positivity is there, then those hormones, or in the case of HER2/neu, that HER2/neu genetic expression will actually help feed that cancer. If it's negative, that means that that hormone is not going to be feeding that cancer. So you could make the argument that if you have a triple negative breast cancer, negative estrogen, progesterone, HER2/neu, there's no issue with putting a patient on hormone therapy at that time. Now, that's kind of radical, I understand that, but that's definitely a discussion to have. And this is talking about systemic hormone therapy. Vaginal hormone therapy, we have proven time and time and time again that really the likelihood of extravaginal, so outside of the vagina, hormone spread from vaginal preparations is almost negligible. So especially, patients who, if they don't have a hormonally sensitive, breast cancer, they can definitely be on vaginal estrogen. That's not an issue at all. And even if they have an estrogen receptor positive breast cancer, if they are post-treatment, that they're kind of in that time span after they've had, the radiation, immediate chemotherapy, lumpectomy, whatever it may be, they can still be considered a candidate for vaginal, especially low dose estrogen therapy. So like a 4 microgram dose, or my favorite vaginal, medication, Intrarosa, is perfect for these patients. So the caveat, obviously, is that you need to discuss this with the oncologist. And unfortunately, that's where we actually get a lot of, pushback. And this gets into the whole knee-jerk reaction thing that I was discussing about earlier in the week. Even if the data is new, the knee-jerk reaction is, nope, hormones are bad. And what a lot of these patients have been told, and I would dare say this is incorrect for a large number of them, is that their hormone use is what caused their cancer. Nah, that's not necessarily a true statement. With some very specific exceptions. But they've been told that, and so trying to say, hey, patient, here's the data, you can be on this. They've been told, though, that their hormone therapy caused cancer, and if you've ever met someone who's been through cancer, they don't ever want to go back there again, so they're not going to take that. So it is definitely kind of a struggle, but the bottom line is that for the vast majority of patients with breast cancer who have had them, they are candidates for hormone therapy, especially for vaginal therapies. Now, you do have to weigh quality of life and all the things like that. And there are some really good non-hormonal therapies too, for things like vaginal dryness, painful intercourse. There's vaginal moisturizers, vaginal lubricants. I talked about that earlier in the week. There are other things too. There's some of the laser-based therapies, like Mona Lisa Touch and things like that. And so all of those things can be used in addition or in place of, but still the gold standard is hormone replacement therapy for these patients, because that is what the deficit is. The other things are just band-aids. You're just kind of, covering it up. But the actual issue is because that hormone is depleted. So anyway, the take-home message is, if you have had breast cancer, even if it's estrogen receptor positive breast cancer, the vast majority of patients can have vaginal hormone therapy. Now, systemic hormone therapy, it's a little bit more of a trickier thing. If it's estrogen receptor negative, I still would be very comfortable doing that. If it's ER positive, you really have to weigh kind of like the severity of symptoms. And, they did see that patients who were on hormone therapy, systemic hormone therapy, had a lower all-cause mortality than those who were not, even in patients who had been diagnosed with breast cancer. So, like I said, this is very much a your mileage may vary, an individualized thing. But like for the vast majority of patients, and different studies have shown that there was actually no increase, even in systemic estrogen therapy in patients who had had breast cancer, in reoccurrence of their breast cancer there. So that's the take home for that. Uterine cancer, there are the vast majority of endometrial cancers that we deal with are due to kind of unopposed estrogen or too much estrogen that's going to the lining of the uterus. So progesterone therapy, or progestin therapy specifically, is actually part of the treatment for that for a lot of patients. And so that's totally fine. Providing estrogen therapy to a patient who is actively battling endometrial cancer, I don't really agree with that at the time being. And honestly, for a large number of endometrial cancer patients, their treatment is removal of, the uterus, especially because endometrial cancer is kind of different in how it grows. But like I said, I think, especially things that have shown no endometrial spread, like in Intrarosa or the low-dose, vaginal estrogens, I think you could once again make the argument that that's totally fine for those patients. Ovarian cancer, very few ovarian cancers, especially in postmenopausal patients, are hormone related. And so that's kind of not going to, that's an issue that you can really look at and kind of say, hey, for the vast majority of these patients, that's going to be okay. Non-hormone based or non-gynecologic based cancers, you're probably just fine just doing your normal stuff. If you have, a squamous cell carcinoma or a basal cell on your nose or something like that, it's not going to be affected by hormone therapy. But yeah, so I think the take-home method of this, whole week is, we want to do science, not fear. And, for so many patients who have struggled with the sequelae of cancer, there's still that fear there that hormones are bad and hormones are causing issues. And I really want to try and get that out there, that you can still be treated with these. We can help your lifestyle be much better. You can have those benefits of you don't have to have the vaginal dryness and all the, pain with intercourse. Hot flashes, some of the systemic symptoms. There are actually a lot of non-hormonal therapies that work really well for those too, so talk to someone who's knowledgeable about this stuff. I think that's the big thing. That maybe that's even the more take-home message, is find a provider that, especially if you are menopausal, who's NAM certified, that is knowledgeable about these things. Like this is, we get training in this, I'll talk all day long about hormones if you want, so it's, do your research. You obviously are the best advocate for your own health, but find someone that you can work with that will help, kind of really get you to be where you want to be, and know that there is hope. There are therapies. This is not like once you have cancer, your reproductive organs all go, to hell in a handbasket, and everything's dry and terrible and things like that. So anyway, if you have questions, please let me know. Otherwise, thanks for watching this. Please share and like and subscribe and all that stuff. I'll talk to you next week.